Hi, I'm Chris, and for my policy analysis paper, I chose to present over excise tax on high-cost employer-sponsored health coverage, commonly referred to as the Cadillac tax. The outline of the presentation is as follows. I'll give a brief introduction of the tax policy itself, define the problem prior to the enactment of the ACA, discuss analysis criteria, which include the subheadings population benefit, cost, administration, and stakeholders. And finally, we'll wrap up with policy evaluation. So to begin with the introduction, the Cadillac tax imposes a 40% excise tax on the difference in cost between employer-based insurance plans and the established thresholds designated by the ACA. When the ACA was enacted in 2010, the Cadillac tax was originally scheduled to begin on January 1st of 2018, but this actually didn't happen. There was a couple of pushbacks, the first being to 2020 and the second being to 2022, actually, that just happened in January of this year. So the annual thresholds for the calendar year 2018, as assumed by the original placement of the Cadillac tax for the ACA, for self-coverage and family coverage, those limits are $10,200 and $27,500 respectively. The self-only threshold is multiplied by a health cost adjustment percentage based on the difference of the cost of the employer-provided plan and the cost of a federal Blue Cross Blue Shield plan. There's also an age and gender adjustment. There's also an increase in threshold limits for retirees and for individuals who perform jobs with excess risk, such as electrical and telecommunication line workers. In the case of these two situations, the threshold values are adjusted to $1,650 and $3,450 for self-only and family coverage, respectively. The threshold limits assigned for the self-only and family coverage plans will change based on a 1% cost of increase or cost of living increase after calendar year 18 until the end of calendar year 2020, as it was originally supposed to be implemented. The ACA further specifies any value obtained as a result of the adjustment discussed will be rounded to the nearest $50. The value of an employee's health coverage cost is determined by the total cost paid by both the employee and the employer for premiums, health savings accounts, and medical savings accounts, and other employee-sponsored pre-tax contributions. The total value of an employee's coverage doesn't include the cost of eye or dental care or plans or contributions that are paid after assessing income tax. The statute for the excise tax is 124 Statute 848, which alters the IRS tax code, which is found in Title 26 of United States Code 4980I. So understanding and defining the problem. The purpose of the Cadillac tax essentially can be split into two different categories. The first being to reduce cost of healthcare spending by Americans, and the second being to help pay for healthcare expansion as part of the ACA. One of the objectives of the ACA was to provide better quality of care to individuals seeking care. The U.S. tax system prior to the implementation of the Act essentially used a tax subsidy that allowed employees who took part in employee-based insurance plans to pay their premiums prior to calculating income tax. So this caused a reduction in the amount of income tax individuals paid during each pay period, which reduced the available funding to support medical and other programs, federal programs. The loophole made available by this tax law changed the way employers compensated their employees. The employers began offering higher cost comprehensive plans in combination with reduced wages as compensation for their employees. These high cost comprehensive plans led to overuse of the medical system by the employees. And in this sense, the term overuse, we're talking about excessive medical testing or doctor's visits that aren't necessary. And that kind of increases the amount of healthcare, the money spent on healthcare by the individuals each year. The comprehensive coverage allows the policyholders to utilize a variety of providers and eliminates the need for them to shop around for an effective and efficient provider, which helps increase that cost. So the greatest effect of this prior ACA tax subsidy policy is the overuse of healthcare. The lower income populations are the most affected by this kind of policy because of the reduction in wages and additional medical costs. The reduced wages and additional costs limit the funds they have available for food, mortgage, and other necessary expenses. Analysis criteria, population benefit. So the excise tax on these healthcare coverage plans hasn't taken in effect, as we've said before. Some of the arguments that have been made are that the reduction in premiums as a result of the tax will not result in wage gain. The opposite being the cost of the high coverage plans. So there have been suggestions that limiting the amount of coverage will cause employees to be selective with their health care, which result in two outcomes. The first outcome being that lower paid workers will sacrifice their health to avoid incurring any additional debt. The second is that they may actually result in people receiving better quality care as a result of shopping for efficient and effective providers. Cost. So it's hard to judge the cost associated with this policy since it hasn't been implemented yet. Initially, there was an assessment done where economists believe that as a result of the original schedule of implementation in January of 2018, that there would be a savings in health expenditures of approximately $40 billion and an increase in employee wages by $50 billion annually within the first 8 years of that implementation. And in 2015, a panel of 100 economists wrote a letter to Congress suggesting that the Cadillac tax would be an effective way of controlling these out-of-control medical costs, and that repealing the policy would increase the national debt. So administration. The excise tax on these employee-sponsored coverage plans is implemented through the IRS. The employer that provides the employee access to the medical coverage is responsible for correctly calculating and reporting the dollar amount over the threshold limit to the IRS. The employer is also responsible for paying the 40% excise tax. The IRS issued a notice in 2015. It was notice 2015-16 that began implementing the process and taking comments to start developing this tax. And lastly, stakeholders. Essentially, the stakeholders that are involved are going to be the employers who provide these high coverage plans. It's also going to be the employees, which they'll be encouraged to change their behaviors and be more selective with the healthcare providers and medical testing that they do. And the last stakeholder will be the IRS themselves. They're going to have to develop a policy to implement this. So, evaluation. The major benefit to this policy is assumed to be the reduction of healthcare expenses on an annual basis for individuals with employer-sponsored health coverage. This, again, is hard to determine since the policy hasn't been implemented yet. The revenue generated by the implementation of the tax was believed to be upwards of $25 billion for the 2018-2019 years. There again, on that original schedule of implementation in January of 2018. A major deficiency of the plan, one that's been argued quite a bit, is the inadequate nature in which the threshold limits increase over time. The thresholds established originally in 2010 were set to increase by the Consumer Price Index plus 1% until 2020, and then the CPI again each year after that. There's much concern that the CPI increases won't adequately mirror the rate increases associated with the medical expenses and the plan premiums. One study I found actually indicated that by 2029, that 75% of the employer-sponsored health plans would exceed the threshold limits set by the ACA. In conjunction with this concern, going back to the original timeline, there were estimates that 25% of the plans in 2018 would exceed that threshold. There's also concern that the tax will generate increased rates of underinsured due to the increased premium costs and higher deductibles. So there's been some suggestions for alternate plans that benefit the American public in the same way. Implementation of a cap on tax subsidies would be one way. This limit would generate tax revenue to support federal programs. The cap would allow lower income employees to have more buying power or more efficient health plans while limiting the loophole utilized by the wealthy. The cap would be less involved and easier to implement by the IRS. Essentially, all that they would have to do would be just to create a written policy.